Good afternoon, everyone. I just wanted to provide you guys with a recording of me going through the entire clinical prep for the fall 2020 semester and how to make sure that we're managing our time, prioritizing what items should be completed prior to coming to clinical, what items should be completed during the first 45 minutes that you're allowed on the computer to look up your patient, and then what information and how to manage your time appropriately when you're on your clinical unit. I do want to apologize if Luna starts barking in the background. She seems to keep whining and looking at me, so I want to apologize before I get going. So here we have on the first page, you see a majority of this information really is specifically found on Sorian in the patient's electronic health record. So everything from diet, ambulation, I's and O's, if there's any tubes, drains, what precautions they're on, why are they here, what's their past medical history. All of this is going to be found in your Sorian record. Going to move on here to page 2 of the clinical prep. Something that might be helpful for you is to start filling these out prior to coming to clinical, just so that way you're not missing points for lack of units for your vital signs or specific sections of your head to toe physical assessment. As previously mentioned in the past, we do learn some of these items on the head to toe assessment we haven't physically learned yet. So as of right now, we're just sticking to the basics. As we progress through the course, you will become more familiar with certain aspects of the head, eyes, ears, nose, and throat assessment, neuro assessment, etc., that you'll be able to beef these up a lot more. Percentage, pain scale out of 10. So head we're looking at, is the head symmetrical, no lesions or masses noted. You're going to want to write these in pencil, so that way these are helpful tips when you're going into your patient's room to conduct a physical assessment. These are what we're going to find as a generic or baseline for a normal patient that doesn't have comorbidities, or on the flip side, just some very common things that we might find, for example, under eyes if they have glasses. You might write that in pencil, and then if we get to clinical and you note that your patient doesn't have glasses, you can always at clinical just type no or write no before glasses. So these are just some helpful things that you can prep for prior to coming to clinical. They have hearing aids or they're hard of hearing. Their nose is patent. Mouth and throat, no swallowing. Teeth. Maybe they have dentures. That might be something you want to look for. Coming down here to neuro, we're looking at alert and oriented ×3. No confusion noted. Cardiovascular, we've talked about this. We learned this on week 1 of class. Something that might be very helpful for you to make sure that you're covering all necessary contents within the systems is printing that head to toe with comments I sent you guys in the email last week. That's really helpful, and it really does thoroughly discuss every single system and how to perform the assessments. It really clarifies a lot of that. So I would write maybe in cardiovascular, S1 and S2 present. No murmurs noted. Palpable pulses, times, leave that blank. No edema noted. Cap refill, less than, and I probably leave that blank. Thorax intact. No open areas noted. Under respiratory, we would move to, sorry, clear lung sounds auscultated bilaterally. Patient on room air. No dyspnea noted. No use of accessory muscles noted. Chest or maybe skin intact. No lesions and no cough noted. GI, we're going to be learning about that this week, but right now we're going to think about nausea, vomiting, diarrhea, last BM. If you saw their last BM, what did their last BM look like? Under genitourinary, we're looking at, do they void independently? Are they incontinent? Same thing with GI, are they incontinent? I swear, she only is crying because she hears me talk. Note that when I stop talking, she stops whining. So I do want to apologize. Musculoskeletal, any fractures? How do they walk? Integumentary is pretty self-explanatory. Do they have any open areas, lesions, wounds, dressing, wound vac? That would be all here. And then obviously your vascular access device. So moving on to page 3, we can be sure to fill out all of this normal value before you guys come to clinical. You have to be sure that you're not, you know, photocopying it every week to week. The whole purpose of doing this is to, oh, sorry, I guess that did not highlight the way I wanted it to. There we go. The whole purpose of you guys physically handwriting the normal values every single week is so that way you guys muscle memory, you're writing it all the time, you're looking at it all the time. It does help with studying techniques. It'll help you for the boards. It'll help eliminate having to constantly memorize and understand different lab values, because if you're writing them and you're looking at them week by week, there won't be the case of forgetting or having something become dormant that you're not really talking about that much anymore because you're constantly writing it. So this whole column here could be filled out prior to coming to clinical. And then in addition to that, this interpretation column can also be filled out prior to coming to clinical. So when I say interpretation, I'm looking for, if the sodium level was altered, what would you see? Maybe you would see dehydration. Maybe you would see fluid volume excess. For potassium, if there was a alteration in normal range, maybe I would see some EKG changes. Under BUN creatinine, maybe I would see acute kidney injury. Maybe I would see, for glucose and hemoglobin A1C, a diabetic. The whole purpose of this, again, is to try to enhance your guys' understanding and critical thinking. So when you do go into clinical and you're looking at the baseline and the most recent, you can identify that, hey, maybe this patient came in 2 weeks ago, and they were in fluid volume excess, and now today I'm looking at it and I think, wow, their sodium is normal. What have we done? What has been done within the medical time frame or the patient's hospital stay that warrants that sodium to be within that normal range now? So again, it's just all about that critical thinking. These can really be the same week by week, and it's just help. There really isn't one specific answer that we're looking for. We just want to see you guys starting to tie these lab values into certain disease processes or changes in patient condition that you could start seeing when you're at clinical. So next page would be, I don't know what happened here. Next page, we would see the nursing diagnosis. Please make sure that you guys are citing your resources. So your citation would be a parenthesis with the author's last name, the year, and the page number you found your nursing diagnosis from. We all know that nursing diagnoses are national, they are standardized, we use them everywhere. So these are not nursing diagnoses that you're going to come up with. They have come from somewhere, some sort of a resource, whether it be your Sparks and Taylor book or Lippincott Advisor. You're going to find those nursing diagnoses from some resource. So please make sure that you're citing those. And then you would have your reference on the back that this citation would coordinate with. So looking at nursing diagnoses, we want to make sure that we're starting at the top, at the data cluster. So the data cluster, think of it as your piece of paper that you come into your exam. You get a blank piece of paper at your exam and you start dumping all the information that you know about whatever the topics are that you're gonna be tested on in that exam. So you're gonna write everything in this data cluster that you know is going on with your patient. So for example, one of the examples I used in class was a COPD patient. You have a COPD, maybe they have COPD, maybe their O2 stat is, I don't know, 91%, they're on 3 liters nasal cannula, they have a history of hypertension, anemia, BPH, they have a Foley catheter, they are incontinent, they have wounds with daily dressing changes, they have they're hard of hearing, they are on bed rest, they're NPO, they're not eating or drinking anything. So this would be my data cluster. And as you can tell here, all of these don't necessarily connect. They are what you're physically seeing that's happening with your patient. So nursing diagnosis, one that we could use is risk for infection. That's straight from the book. And that could be maybe related to maybe the fact that they have BPH, and it's as evidenced by the patient has a Foley catheter. So we all know that patients that have catheters are at risk for infection because that is a central avenue directly into the patient. So if we're not cleaning frequently and practicing hygiene frequently, our patients are going to be at an increased risk of infection. So pretty straightforward. The patient will, we have to think about what is something that us as nurses would be able to measure. So we're not going to, or control. We're not going to be able to just control our patient's white blood cell. I want to make sure that my patient doesn't get an infection. Maybe I want to look at the urine coming out of the Foley catheter within my shift to make sure that there isn't any significant change. So the patient will display clear yellow urine within Foley bag by end of shift. That's a SMART goal. It's specific, it's measurable. The time frame here is end of shift. Maybe your time frame is in 2 hours. We can talk about that. I'll do another one below. So what am I as the nurse going to do to make sure that this patient's urine doesn't change? Well, I definitely would want to make sure I the nurse will perform perineal cleansing prior to breakfast using CHG wipes. That's measurable. We have a time frame. It's specific. The nurse will, our patient is NPO. Maybe we want to talk about infection, so we have to think what else could display if a patient is having an infection. We could, the nurse will assess oral temperature, Q4 hours to be sure patient is afebrile, specific, measurable, has a time frame. And then lastly, maybe the nurse will empty Foley catheter bag, Q4 hours, and document output amount and clarity, because we want to make sure that we're emptying that catheter bag. There's nothing worse than having a patient have a Foley catheter bag because no one has emptied that. Because again, think about that urine is going to sit in a bag that's connected directly to a tube that's direct into the patient. So thinking about that, that's going to decrease our risk for infection as well. So if the outcome is met, I will find the patient displays clear yellow urine within Foley bag by end of shift. And what I found was the patient had cloudy yellow urine, or maybe foul smelling. Yellow urine at end of shift. Now, does that mean that your goal or your plan didn't work? Absolutely not. There are a lot of different components that could affect this to happen. So we are going to know that not every outcome or not every goal that you create for your patient is going to be successful, and that's okay, because that's all about the nursing process. So again, we're going to talk about the same patient. So I really have the same data cluster. We're not reinventing the wheel. We have the same patient. We're working with the same patient, so there's no use trying to create anything different. We're going to use the same data cluster to come up with another nursing diagnosis. So maybe, oh, I forgot, this COPD patient was confused. Maybe they have dementia. So maybe our nursing diagnosis could be risk for impaired skin integrity related to confusion dementia, as evidenced by wounds and being on bed rest. Right, so we know that patients that are on bed rest are going to be at an increased risk of skin breakdown. I mean, there are so many you could choose here. You could choose that they're incontinent, that could cause them to have skin breakdown. You could write that they're NPO, that could be at risk for skin breakdown. And so the patient will, we're talking about wounds and they're on bed rest. The patient will will have daily wound dressing completed with a clean, dry, intact environment by end of shift. So time frame would be end of shift. The nurse will turn and position patient Q2 hours. So we're looking to prevent skin breakdown. The nurse will, I mean, we can think really outside the box here. We can talk about advocation. The nurse will advocate to provider supplemental nutrition. by 10 o'clock. And let's see, we're turning and positioning our patient. The nurse is going to change the wound dressing. The nurse will change wound dressing per MD order by 11 o'clock. If the outcome is met, I will find the daily wound dressing changed and clean, dry, intact by end of shift. What I found was the dressing was changed and clean, dry, intact. Very straightforward. Please don't think outside the box. We have to think about what can we control. I mean, we could talk about many. We could talk about their COPD, but remember, O2 saturation is 91%. That's not necessarily going to change. We're not going to be able to cause our patient to have an O2 saturation of 100% by the end of our shift. We're not necessarily going to be able to titrate down our patient's oxygen needs. So if they're chronically on 3 liters at home for their COPD, we're not going to be able to affect that. We can't say the nurse will get my patient to be on room air by the end of my shift. That's not realistic. That's not appropriate for our patient. So we have to think about that. But again, please just try not to think outside the box. I'm thinking that these are pretty generic, straightforward. I mean, there's risk for falls. We have impaired tissue perfusion. We have fluid volume excess. There are multiple nutrition ones. There are multiple activity intolerance is another one. So there are a lot of generalized ones that we can talk about here. So moving on to the medication page. So all of these columns really would be filled out within that first 45 minutes. I would tell you that if you find that you're having a little extra time in that first 45 minutes, once you've completed page 1, wrote down the baseline and the most recent lab values and wrote these down, my next suggestion to you would be to start writing down the implications. So why is this patient on this? So why is the patient on this medication? Is it for blood pressure control? Is it a vitamin? Is it a supplement? Is this a bronchodilator because they have, asthma or bronchitis? Medication page, pretty straightforward. Moving on to the teaching plan. So we're looking at the assessment, pretty much laid out similar to the nursing process. So assessment, who are you teaching? The patient. Are there any barriers? Do they have hard of hearing, auditory impairments, visual impairments? Are they confused? Is it related to their medical condition? Are they not motivated? Is there a language barrier? What does the client already know about the topic? So think about your topic. We are always, as nurses, trying to assess what our patients know, our students know, our peers know before we go ahead and start teaching them. Because there's nothing worse than to start a teaching plan and come to find out your patient already knows everything about the topic that you've already started teaching. So we're going to evaluate their understanding first. So tell me what you know about this, and hold up their call light and see if they know that, if I push the red button here, I'm going to be able to call the nurse. So my teaching plan is going to be a little different. My method down here will be focused more on reinforcement rather than teaching new material. So the topic being taught, lots of different things. Fall precautions, safety precautions using the call light, ambulation, dietary needs. We can definitely go into teaching patients about medications. Now that you guys have completed your medication validation, we can talk about medications with them. We can talk to them about wound dressing changes. We can talk to them about vital signs. I would caution you to teaching a patient about a disease process. I would suggest you to go to your clinical instructor and run the content by your clinical instructor prior to going in and teaching a patient that's newly diagnosed with diabetes or a new diagnosis of hypertension or something like that, just because we want to make sure that we are providing the best information possible that's going to be a successful teaching plan. Information used to reinforce material. Maybe you are using lip and cup. Maybe you're using some tool. Maybe you're using the call light. So what are you using? How are you reinforcing what material you're teaching? Teaching method. Are you verbally discussing this? Are you demonstrating it? Are you reinforcing? Are you giving them, I don't know, a quiz on it? Goal, what's your goal? Do you want your patient to be able to use your call light? Do you want your patient to be able to walk 240 feet around the unit? Up here, so this is just the implementation phase. I want you to tell me how you taught your patient or your client. Talk to me about it. Pros, cons, if there was something that you found halfway through, that's okay. It's not supposed to be perfect. This is supposed to be a learning experience. And then down here under evaluation, so how did you evaluate the effectiveness? Did you have the patient teach back? Did you have them give you return demonstration? Did they discuss it with you? Again, that really falls into the evaluation method. Those are very similar. And then the client's response. Did they like it? Did they ask any questions? Did they have any concerns? Reflection on your day. Basically just talking about how was your day? Was there anything positive that happened? Was there anything that you'd like to change? This is a great time to reflect to enhance your learning for the next clinical week. And then nurses note. So what information is important to include here? We really want to see you guys talking about your ADLs. So what did you do with your patient? Did you bathe them? Did you help them bathe? Did you help them eat? Did you set up their tray? What was the percentage of what they ate? Did you empty their Foley catheter? How much did you empty out of the Foley catheter? Did you give them a full bed bath? Did they need help? Were they an assist? Did you have to set them up? So really just talking about your day. I love seeing you guys talking about admitting, diagnosis, and kind of the story on what's going on with them. I'm seeing that a lot, and that's wonderful. I like seeing you guys say, patient presented to the emergency room with blank symptoms. Patient has a history of blank. These are the medical interventions that were completed on the patient. That's really telling us the story, and that's giving us that situation and keeping your nurses note in that SBAR format. That's really helpful. SBAR, if you're having a hard time organizing your nurses note, putting it into the SBAR format, I highly appreciate, even if it's segmented to S, B, A, R, and then you write your information next to it. That's a great way to organize your information. I want to know maybe if there was any medication implemented. I want to know if you did vital signs. What were they? Maybe a finger stick. Maybe I would love to see your assessments. So your cardiovascular, your respiratory, abdominal. This is a great way, again, just to include this. So think about, I'm the nurse that's coming in to take care of your patient. You really want to make sure that you're telling me everything that's going on with this patient, so that way I can adequately care for them and know what your plan was and how your day worked out, so that way I can try to pick up the pieces. We have to keep in mind that healthcare is 24/7. So I feel that as nurses, we are trying to accomplish so much within our shift that we forget that there are other shifts and other times that we can also prioritize and delegate different interventions, educational topics, etc., so that we're not overloading our patient and putting, having too high of expectations for them. Your nurse's note should definitely be one of the last topics that you would be completing in your clinical day. because this is your story of your entire day. So I would suggest you to maybe jot some notes down on a blank piece of paper of some items you'd want to include in your nurse's note. But I would suggest you writing your nurse's note within that 12:30 or 12 o'clock to 12:45-ish when we leave the floor, that end of your clinical shift, before you hand it in. So I am hoping that this was helpful for you guys. I know that sometimes the clinical paperwork becomes a little overwhelming. We have to keep in mind that it is worth 3.5 points, so this is not something that should be taking up a majority of your clinical day. We want you guys to be mindful of this. A lot of this information are required pieces to being able to safely care for our patients, but we really don't want you guys to be spending your entire 6-hour clinical working on this paperwork. It's a helpful tool for you guys, but our sole purpose as nurses is to be hands-on with those patients on the front line caring for the patients. The documentation aspect is very important and required as nurses legally, but not a priority when it comes to actually caring for the patient. So I did want to just set that precedent as well, that this paperwork is really important, but hopefully identifying different areas that you can start to fill out prior to coming to clinical, knowing what items you should be filling out within that first 45 minutes will really complete your clinical prep and have you be a little bit more prepared for when you actually go to the clinical environment, that you don't feel overwhelmed with having to fill out this document and you can really focus on your patient because a lot of this stuff has already been completed. If you have any additional questions or any of this was confusing to you, I definitely suggest you guys to reach out to me. I would love to meet with you and talk to you. I feel like the common question is the nursing diagnosis and the physical assessment piece. Again, that head to toe with comments that I sent you guys last week in an email is really helpful for breaking down the physical assessment. And if you guys are, but I'm absolutely more than willing to sit down with you guys and go over the physical assessment, whether it be in clinical or after class or in lab. And then the same thing with the nursing diagnosis. More than happy to help you guys. Please come seek us out when you're in clinical so that we can try to work through this with you guys so that you are more comfortable and confident with filling out your nursing diagnoses. Again, if you have any questions, just feel free to email me. Have a good day.